Few other things at the end I want to mention is some of these unusual retroperitoneal pelvic tumors. Now we know that we're usually looking at ovaries and uterus, but there are other soft tissues all around the pelvis, and masses could arise from there. There's fat, there's connective tissue, fascia, muscle, blood vessels, nerve tissue, lymph tissue, all kinds of embryologic tissue remnants. So we can have lipomas, fibromas, hemangiomas, spindle cell tumors, neurogenic tumors, teratomas, all kinds of tumors occurring from tissue other than uterus and ovaries. They can be benign or malignant, like fibroma, fibrosarcoma, lipoma, liposarcoma, and there could be various combinations of these tissues, like angiomyxofibroma, hemangiopericytoma, angiomyolipoma, etc. So occasionally we'll see a pelvic mass. Now this is the uterus, transverse pelvic scan. Here's the uterus endometrium. And in the right adnexa pelvis, there's this very lobulated, solid looking mass. We do transvaginal and that confirms. It shows us things a lot nicer, the soft tissue differentiation here. But all in all, it's a solid mass. It's sitting right up next to the uterus. We found the ovaries separately, so it's an extraovarian, extrauterine solid mass. Didn't really know what it was related to. Did some more investigation. CT didn't help. It just showed a solid mass pushing the uterus. MRI was kind of unusual, showing these kind of papillary projections. They weren't sure what it was. Surgery showed a spindle cell tumor of some kind of smooth muscle origin. So they called it a stump tumor, a smooth muscle tumor of unknown malignant potential. Where did this arise from? Did it arise from the pelvic sidewall, from a smooth muscle in vessels, whatever? It's doubtful that this was a fibroid. Here's another patient. This is a doctor's wife who had had pelvic pressure and pain and rectal discomfort, constipation, and ultrasound was not clear. It showed something, but it was just very difficult to scan. So we went on to CT, and there's a mass deep in the pelvis here. There's the rectum being pushed over. She has a pessary in place, so disqualify that. But the mass is solid and pushes into the soft tissues around her rectum. It's growing into the ischiorectal fossa, and it's actually growing so far down that she's sitting on it and is very uncomfortable here. Surgery revealed an angiomyxofibroma. Of course, the doctor's wife has to have a very unusual problem. And here you go, an extraperitoneal, unusual pelvic kind of tumor. In conclusion, I would like to talk a little bit about some abdominal wall masses, because patients who come for a pelvic ultrasound because of pelvic pain could actually be having pain related to the abdominal wall. As you talk to them, they seem to say, well, it isn't really down there that deep. It's really over here. And they point directly to the abdominal wall, where we can find hernias, endometriosis, and even unusual tumors like desmoids. So abdominal wall hernias, hernias in general are the most common abdominal wall mass. When the hernia is in an obese abdomen, it would be very hard sometimes to differentiate it as a hernia because it feels like a mass. These are related to fascial defects. It might just be an incisional defect through which herniates bowel loops, omental fat, and including fluid sometimes. You can cause maneuvers, ask the patient to cough, do a Valsalva maneuver, and the hernia becomes more prominent. You can push it, try to push contents back in, see if it's reducible. So those are the hernias. But abdominal wall endometriosis sometimes is a little more complicated, because it can look like a very ugly, irregular, solid mass in the abdominal wall. And people who have no experience with this may think this is some kind of a malignancy, like sarcoma, Maybe this needs biopsies, etc. You should know that endometriosis seeds abdominal scars in about 1% of patients with C-section scars and other scars in the abdomen, even in the track of a laparoscope that even goes through the umbilicus. It can track into that area of scarring. Ultrasound is the best technique for imaging these things. Shows us a very nice resolution of this solid tissue. CT and MR are not that specific. These are usually solid masses with very regular borders. And on talking to the patient, you can elicit a cyclic type of pain. You can use color Doppler, and you can guide a needle into it and actually do a biopsy if you're not certain. And the last case, I want to show you something that sometimes we get too complacent. We see masses and fibroids and ovaries, and we just kind of routinely go through these cases, but we have to back off once in a while and try to work things out. This patient had a mass, and it was pressing on her bladder, the mass was, she also had a fibroid here, bulging from the anterior wall, and here's the rest of her uterus. And this mass was lurking out here and was thought to be just another myoma. At surgery, it was proven to be a desmoid tumor. This was not related to the uterus at all. This is arising from the fascia or the aponeurosis of the muscle in the abdominal wall, often at the site of a previous scar, and was a completely separate tumor, had nothing to do with her fibroids, just was similar. Maybe if we would have worked this out and tried to move this, we would have seen that it moves separate. We would have known that the ovaries are separate, and maybe we would have placed this as an abdominal wall mass, I'm not sure, but it was just mistaken for a large fibroid. So anything can happen. We see GI, GU, vascular, all kinds of tumors. Ultrasound shows many non-gynecologic findings. CT, MR help to further define the extent and the origin, and often these examinations, ultrasound and CT, are complementary, and MR usually comes to the rescue and becomes the most definitive test. So that's the end, and thank you for your attention.